Hello everyone and welcome to CRAMSURG, Clinical Research Appraisal and Methodology for Surgical Trainees, where we pick a paper fresh from the press on a hot general surgical topic. We review it for you, we present it for you, we critique its methodology for you, and provide top-of-the-field expert opinions and teaching on research appraisal and methodology. My name is Gio Perrin, and together with Professor Saba Balasubramanian, Adam Haig, Ben Wood and Josh Lau, we bring you CRAMSURG from the wonderful region of the Yorkshire and the Humber. Today we will be having a look at a paper entitled Incidence of Geriatric Trauma is Increasing and Comparison of Different Scoring Tools for the Prediction of In-Hospital Mortality in Geriatric Trauma Patients, which was recently published in the World Journal of Surgery. This will be followed by a teaching session by Professor Saba Balasubramanian on Understanding Diagnostic Tests Part 2. In between the two, I will try and give you a very brief overview of the discussion we had during the live session for the paper itself. Enjoy!
Hi guys, my name is Mo. I'm one of the orthopaedic trainees at Hull at the moment. So considering I do trauma and orthopaedics, I thought we'd start to discuss a trauma paper today. So the paper we chose is the incidence of geriatric trauma is increasing in comparison of different scoring tools for the prediction of in-hospital mortality in geriatric trauma patients. This was published in the World Journal of Emergency Surgery this October by Zheng et al. And today, myself and Gio will be presenting for you, and Prof. Balasubramanian will be our moderator. So, the journal. So the World Journal of Emergency Surgery is a subgroup of the BMC, which is Biomed Central. That's UK-based, which is part of the Spring and Nature group. The journal itself was founded in 2007. It's the official journal of the World Society of Emergency Surgery, and it has an impact factor of 4.1, which is actually very similar to many of the more established journals out there, so it's doing quite well. With regards to Libing Zheng, I might be pronouncing that horribly, I'm sorry if I butchered the name. He's an emergency medicine specialist in the Department of Emergency Medicine in Zhejiang University School of Medicine. And he has quite a few papers published around the ICU and trauma patient cohort. So I'll let you...
Let's dig into a little bit of background and why this paper is important. Well, we do know that trauma is a very common cause of death throughout all age groups, particularly in young people. But it's significantly increasing throughout the world in the geriatric population as well. And we do know that all people that do suffer from trauma tend to have a poorer prognosis for various reasons, from their limited physiological reserve to the multiple other medical problems that they tend to have, and obviously medications such as blood thinners that can complicate their management quite significantly. There's quite a few outcome predictors available in the literature, both for the general population and for the geriatric population. But very few are actually validated specifically for the elderly. And this paper fits very well in that category, looking at various different type of predictors and trying to define if they are good enough to predict mortality, not so much morbidity, mortality. So there's two aims really for this paper, and these two aims will kind of come with us throughout the entirety of the presentation. The first aim is to determine whether geriatric trauma is actually increasing in prevalence throughout the world, not specifically in a particular country. And the second aim is to evaluate the ability of 5 outcome predictability scores in terms of determining patients' prognosis and particularly death. So I'll give the floor to Mo to talk about the scores that they will be using in this paper.
So we're going to quickly have to fly through some of these scores. So there's 5 that this paper basically describes: the ISS, the NISS, the TRIS, the Apache, and the SPAS-2. So the ISS is the injury severity score. It's an anatomical score. It was theorized by Baker et al. In 1974, and it is based on 6 standardizing severity of traumatic injury and the worst injury in 6 body systems. It has a max of 75, and basically it allows us to get a general overview and predict the mortality based on these injuries. The problem with that one is it didn't really tend to include if there was multiple severe injuries in one body part. So they came out with the new ISS, and that takes the 3 most severe injuries, even in the same body part, to stop underestimating or underrepresenting the severity of trauma sustained. The TRIS is a mix of anatomical and physiological measures. So in theory, it should have a high specificity for the predicting mortality in trauma patients, and that is based on the revised trauma score and the injury severity score. The TRIS has become the standard approach for evaluation of outcomes of trauma care in many trauma centres, and that was theorized by Boyd et al. In 1987. The Apache score, so many of us are aware of this one, it's a physiological score. The Apache 2 score is a pro estimate of ICU mortality based on laboratory values and patient signs, taking both acute and chronic diseases into account. The data should be from the initial 24 hours of the ICU admission, and we should be using the worst values that we get on that day. So we go on to the SPAS-2, which also uses 12 routine physiological measurements along with the age and the admission type. And this is the simplified acute physiology score. So 24 hours after admissions to ICU, the measurements should be completed and an integer is given between 0 and 163, which translates to a predicted mortality between 0 and 100%. So I've literally whizzed through all of those. I've got all these papers at the end as references just because we need to make time for the rest of the presentation. But I thought I'd just give a quick overview of what these scores are so that the rest might make a little bit more sense. So we've got 2 anatomical scores, 2 physiological, and 1 that's TRIS, which is a mix of both. So, Gio.
Right, so going back to our study. So this is a retrospective cohort study based on databases, I would say. As we mentioned originally, there's 2 aims here. So aim 1, if you remember, was to evaluate whether the prevalence of geriatric trauma is increasing throughout the world. In order to achieve this, the authors looked at 2 big databases, one from the United States, the NTDB, and one from Germany, DGU, in 2 different, slightly different time frames. And they look at the amount of patients recorded in that database of age 65 or above, or 60 or above, depending on what database we're talking about. And they simply look at how that number has changed in time throughout those about 10 years. Concerning aim number 2, they actually take a database that was used for another trial, another study in Switzerland, including 300 severely injured geriatric patients, and they perform a secondary analysis on that cohort, trying to determine whether the scores that we just discussed were able to predict mortality and outcomes in that particular cohort. So just remember, there's 2 different aims and 2 very different patient populations here that are being analysed. Mo, back to you.
Yeah. So as Gio just said, there's 311 patients concerning the Swiss database, and they were split into a survivor group and a death group. And for both of those, an AUC ROC score was plotted and evaluated to help us predict the mortality in the geriatric trauma. So that's the ISS, NISS, TRIS, Apache, and SPAS-2.
So very briefly, these are some of the results for aim 1. So the top left chart represents the increment in geriatric trauma patients in the American database. Very similar picture is visible on the middle chart, which represents the overall trend in Germany. And finally, on the right side, this is a little bit amusing to me, it's a representation of the average age of the population in China and how it has increased throughout time. And the author kind of implies that given that the population has increased in average age, probably trauma in the elderly has also increased without really providing much data on top of that. The chart at the bottom end is actually from a different paper. This is UK data. And this is just to highlight how actually the picture is very similar in this country. You can see that trauma in younger populations have remained pretty much static, if not really declining, while it has significantly increased in the elderly populations. So, ball to you, Mo.
Perfect. So back to the Swiss database of the 311 patients, we had 147 who survived and there's 164 deaths. So it was mainly due to blunt trauma from a fall less than 2 meters. And it was found that the patients with a high GCS and hemoglobin tended to be in the survival group, and especially those with the lower age and also a lower lactate on admission. So according to the area under the curve analysis, it shows that the NIS, so the new injury severity score, and the TRIS outperformed the physiological based scores, the Apache and the SPAS. Having said that, the second graph on the right, that was for the TRIS score. Gio, do you know why they represented the TRIS score in a separate graph? Because I couldn't quite figure it out from the paper.
So I couldn't really figure it out either, meaning that the author doesn't really provide an explanation why they do that. The only thing I can think of is that the TRIS does have a different scoring system whereby the scale is inverted compared to Apache SAPS, ISS and NISS. So the lower your score in the TRIS, the higher your mortality and vice versa. Now, I'm not sure that's an adequate explanation because sensitivity and specificity tend to be absolute numbers anyway, as well as should the ROC curve representation. So I'm not entirely sure. I couldn't find out on the paper. I don't know if Prof has any particular ideas about this, but we'll ask him at the end. Ball back to you, Mo.
Fair enough. So with regards to limitations, there were self-reported limitations and some that me and Gio felt we found. So with regards to the self-reported, they've claimed that only 2 country databases are analysed to describe age profile, even though they do briefly mention the Chinese database. They've also completely omitted the use of the GTOS, which is the geriatric trauma outcome score, which I would have thought would have been perfect for this paper, but they've said that they've not used it. They've not explained why, but they've been very clear that they know it exists and that they haven't used it. Also, that they are very aware of the limitations of a secondary analysis of a cohort data. So yeah, they've understood that the data that was collected wasn't quite for the purpose that they've used it for, but they've gone ahead anyway. So with regards to the other limitations, I'll let Gio just touch on those.
Yeah, so there's a few other sort of points that we picked on. As we mentioned, and as you most certainly saw during the presentation, the databases that they use to identify prevalence of geriatric trauma are picked in different time frames, slightly different, but different. Probably different enough to probably say that there might have been some changes in the way trauma gets managed, particularly in the sort of 2010s in various countries throughout Europe with the introduction of trauma centers. Severe trauma is not very well defined throughout the paper, particularly when they analyze the Swiss cohort. It was originally well described in the paper that originally reported that cohort, but not particularly well in this one. I am not sure how relevant the outcome that they picked is. Obviously, estimating mortality for a trauma patient is relevant, is important, but nowadays, especially in the geriatric population, you do want to know a bit more about morbidity and what's the likelihood of a patient not just getting out of hospital, but in what state. They did identify in the 300 odd patient that they included some baseline differences in characteristics, and they did not make any attempt in smoothing down those differences before actually applying the scoring system. So I'm pondering whether they should have perhaps propensity matched the cohorts or use some logistic regression methods to try and account particularly for variables that are not included in the scoring system, such as age, which would be quite relevant in this context. The Swiss database as well is not really put into context very well, meaning that they don't really say if they recorded in the Swiss center they took the data from an increase in geriatric trauma throughout the period of the study. Ball back to you, Mo, for conclusions.
Fine, so let's wrap it up quickly. The bottom line of this paper is that geriatric trauma is on the increase rapidly due to aging populations, and from the area under the curve graphs that the NISS and TRIS basically outweigh the Apache and SAPS2. What I basically got out of this paper is that the anatomical predictability scores are better than the physiological ones in this case. And then we've got this table that summarizes the good and the bad points that we thought were highlighted throughout the presentation. I'm not going to read it out because I think we've said most of the points and it's just humoring you guys. So I think this is the bit where I take any questions. I've got a slide with the references and then I've also got the PDFs of all the papers. If anyone actually wants to go through them, I'm happy to send them through.
In this very brief session, I will try and give you an overview of the most important points that came out of the discussion of this paper throughout the live session. So as you most certainly have noticed throughout the title and the text of the paper, the authors talk about increasing incidence of geriatric trauma in populations of both the United States and Germany. If you look carefully, however, throughout the paper, they highlight how the relative number of trauma patients admitted to hospitals is increasing in comparison to other trauma patients. They don't really specify if the number of geriatric patients affected by trauma over the total number of geriatric patients in the populations in a certain amount of time is actually increasing. So they're not really talking about incidence here. And this brings us back to one of our previous episodes where we encountered a similar problem. If you remember, we were talking about appendicitis in pregnancy. A further very important point here is related to the nature of the scoring system that are compared throughout the paper. So the authors set out to use ISS, NIS and TRIS. These three scoring systems are designed to be used at admission of the patient. They also use Apache 2 and SUPS 2, which are on the other hand designed to be used at admission at the ICU. This is quite a significant difference as both SUPS 2 and Apache 2 can be quite significantly affected by pre-ICU management. And therefore, in real life, differences detected between the different scoring systems would be a reflection, potentially, of pre-ICU settings management rather than a genuine difference between the different scoring systems. To give you an example, patients that did not survive the initial management will not be in real life included in the scoring systems such as Apache 2 and SUPS 2, as they would never really get into ICU. This is an example of immortal time or survivorship bias. Finally, we briefly discussed why the TRIS score in this particular paper is highlighted on a separate chart compared to the other ones, and we couldn't really find an answer, therefore we'll be asking the authors concerning this. Right, I'll leave you with Prof. Saba teaching session. Enjoy.
Yes.
Lovely. Right, so we discussed a little bit about diagnostic tests last time, and these are the points we touched upon. So for each of these diagnostic tests that we do in our clinical practice, there are lots of different parameters that we can use to assess how useful these tests are. We talked about sensitivity and specificity, which includes accuracy as well. We talked about predictive values, positive and negative predictive values, and we talked about likelihood ratios, likelihood ratio of a positive test and likelihood ratio of a negative test. Right, so we then discussed that sensitivity and specificity have a really important role in research and can be used in comparing different diagnostic tests. So you can compare the sensitivities and specificities of different tests, like maybe the use of CRP and white cell count in the diagnosis of appendicitis, for example. But just the values, the sensitivity value and the specificity value is of little use in clinical practice. Yeah, so we discussed an example and we looked at why sensitivity and specificity are not directly useful for the average clinician. We then talked about predictive values, and I emphasized that predictive values have a really important role in screening, and we're going to talk about that again. And we said that likelihood ratios, the likelihood ratio of a positive test particularly, is really useful in estimating post-test probabilities, and that's why likelihood ratios are of value in clinical practice, right? So if you wanted to look back at these slides, then they're there on the YouTube, they're there on the website, so feel free to have a look again. I thought we should cover two other aspects before we conclude the chapter on diagnostic and screening test. One is the ROC curve, and it fits in nicely with the paper we've discussed today. And the other is the issues in relation to screening tests. So let's look at the ROC curve first. Now, if you have a straightforward diagnostic test, and by straightforward I mean a test that will give you a yes or no answer, then it becomes very easy to use that test in clinical practice. It becomes very easy to assess the usefulness of the test. So if you have an ultrasound that you're doing for right iliac fossa pain, and if the sonologist or the radiologist tells you it is appendicitis or it isn't, then you've got a binary yes or no answer from that diagnostic test, and therefore you can go ahead with the next step in your management pathway. If you do a biopsy on a lump in the lung and you're looking for cancer, then you're expecting the biopsy to be either positive or negative, and then you use the positive or negative result to move forward. What if the test is quantitative? What if the test is a number on a scale? Let's consider an example. Let's say there's a new interleukin, and not necessarily 6, but something called interleukin X, that you're researching, and you're looking at the value of that interleukin in the serum in acute appendicitis, and let's say the values seem to range from 1 to 100 picograms per ml, and let's say you've done a study in appendicitis patients and in controls, and you find that this particular interleukin X is higher in appendicitis patients compared to controls. So you've got a mean value of 70 in appendicitis, and you've got a mean value of 55 in controls, and then you've got this dilemma as to what threshold do I use to say beyond this level you've got appendicitis, or below this level you haven't got appendicitis. So in these kinds of questions, plotting this ROC curve, receiver operating characteristic curve, can help you calculate the sensitivity and specificity, or 1 minus specificity, and I'll explain that in a minute, for each value of this particular interleukin. I've got it as peptide here, but let's say this interleukin for the diagnosis of appendicitis. Okay, so here's an example of a ROC curve. We've looked at this in this paper just a few minutes ago. So essentially, in a ROC curve, what you do is you plot the true positive on the y-axis. A true positive is the same as the sensitivity. If you think about it, go back to the formula for sensitivity, you'll realize that sensitivity is the same as true positive. And then on the x-axis, you plot the specificity, or the inverse of specificity, 1 minus specificity, which is simply the false positive rate. So if you take, let's consider this blue line, and let's consider that the blue line represents the value of this new interleukin, and you're looking at it as potential in the diagnosis of appendicitis. What you're saying is, as your sensitivity goes up for any test, the specificity is going to go down, or in other words, the 1 minus specificity is going to go up. So what you say is, because you do not know what value of interleukin X is going to be useful, for every value you plot the sensitivity over 1 minus specificity. So and then you get a curve, and that is what is called the ROC curve, or the ROC curve. Now, in an ideal test, you will find that the curve takes the shape of a straight line going right up, and then cutting across and moving towards the upper right corner of the screen. In other words, a test that is useless or of little value will fall along this diagonal, right? A test that is of little value will fall along the diagonal. So the higher or the further away the curve is from the diagonal, the more useful the test is going to be. So if you wanted a really perfect test, then you will hope that and the curve will be well away from the diagonal following my laser pointer, and then you will be able to choose a point on the curve that gives you maximum sensitivity and maximum specificity, or the lowest 1 minus specificity on the x-axis, and it is furthest away from the diagonal. In other words, the area under that curve will be as high as you can get. So you're looking at the area under the curve, which is the area or the area of the graph that's between the curve and the diagonal. You're looking to see how far away from the diagonal the curve is, and then you're going to decide on the point furthest away from the diagonal in choosing your cutoff. So that is one very important use of the ROC curve. Another use of the ROC curve, as has been described and discussed in the paper, is when you're comparing 2, 3, or 4 different diagnostic scores, if you like, and you want to look at the area under the curve for each of these diagnostic tests, and typically you would choose the test that's got the maximum area under the curve. So that's another useful value of using ROC curves, i.e. you compare different diagnostic tests which effectively are quantitative measures of whatever you want to predict, and you look at the area under the curve. Okay, so hopefully that gives you some insight into what ROC curves are. Right, let's then move on to screening tests. So we talked a lot about diagnostic tests, and I thought we should conclude the lecture on diagnostic tests by talking a little bit about screening tests. The screening tests effectively are like diagnostic tests. You're looking to see how you can improve the prediction of a particular problem or a disease that you're interested in. The only difference between the diagnostic and screening tests are that screening tests are done in a population that are healthy or do not manifest signs and symptoms of disease. So you do screening tests to hopefully try and prevent disease, or you want to detect disease early. It could be population screening, where you're not really stratifying the people you're screening in terms of their risk of having the disease, or you could be doing opportunistic screening or screening in high-risk settings. So examples in surgery would be screening for malignancies like breast cancer and bowel cancer, maybe screening for aortic aneurysm in otherwise asymptomatic people who may be at risk, and also we're all very familiar with the screening for MRSA. You do a swab, MRSA swab, as a preoperative screening tool. So these are some examples of screening tests, and that's why I think we should be understanding the limitations of screening tests, at least the general principles of the pitfalls of using screening tests. Right. So when we talk of screening, you've got to take a step back and have a think about what would be an ideal screening test. It really depends partly on what you're screening for as well, but the World Health Organization laid down a series of principles where they outlined what would be an ideal screening test, and they were talking about this in the context of infectious diseases and also of cancer, right? So essentially what they say is you've got to be screening for an important health problem, obviously. A lot of these are fairly logical and obvious statements, but it's useful to keep them in mind. And they say that you've got to have a simple, safe, precise, and validated test. They say that the treatment of early stage disease, this is in the context of cancer, sometimes, and also infectious disease, should provide benefit, reduce morbidity, mortality, and outweigh harm. In other words, there should be some benefit in screening early, and you might think this is a pretty commonsensical thing to say, but you'll be surprised how many times in science and research we embark on screening without necessarily having a really optimum strategy to implement when you screen for something early. A typical example would be this discussion about screening for Alzheimer's and dementia and so on, when we may not necessarily have effective treatments to institute at an early stage of the disease. So you might just wonder, what's the point in screening and inducing anxiety when you do not have anything to change the natural history of the disease. Obviously, screening should be cost effective, and you need to be able to demonstrate these days that the intervention would then be of some benefit in improving quality of life and improving survival, and it should be beneficial in terms of cost per quality referring to quality adjusted life year. If it's a very expensive test which does not give you enough life years, then obviously many societies will not be able to afford them. And if you're introducing a screening program in your practice or in your region, then obviously there needs to be a plan for audit and standards, and patients should be fully informed not just of the benefits of screening but also the risks of screening. Okay, so the key things to remember is that screening tests are associated with a number of significant limitations, and often we tend to overlook these limitations and focus primarily on the benefits. Now, I won't spend any time on the benefits because they are self-explanatory, but I'll just go through a couple of slides on limitations. Now, there are two important limitations you need to think about. One is called the lead time bias, and the other is called the length time or the overdiagnosis bias, right? So any screening test will obviously end up in increasing the incidence of the problem because you're probably detecting the disease early, and you might be detecting a disease in many instances which may not manifest in the course of the individual's lifetime. Okay, so we'll come to lead time and length time bias in a minute. The other things to consider are the psychological impact of false positive test results. This is particularly important in the context of cancer screening. There's also morbidity of treatment and costs of treatment. And when you look at screening tests in cancer, if you look at the literature, you will find that often the discussion is about reduction in cancer-specific mortality. And people don't talk much about whether there is an impact on overall or all-cause mortality in cancer. So if you look at the trials of screening in bowel cancer and colorectal and breast cancer, you will find that the literature is full of how the screening intervention reduces colorectal cancer specific death and breast cancer specific death, but they keep a bit quiet about overall mortality. And you might think that if you reduce cancer specific death, then inevitably you will reduce overall mortality. But if you think about it, that may not necessarily be the case. It may not be that you're really reducing overall mortality, because you might be picking diseases in an elderly population where there are competing risks to mortality. There might be lots of other things that might influence mortality. All right, let's talk about lead time bias. You've probably heard of this in the context of screening, but here is an explanation. So let's assume that you have a person has cancer, say, at the age of 50 and becomes symptomatic of cancer at the age of 50 and then goes to the GP and gets diagnosed and treated in secondary care, and they succumb to the cancer at the age of 60. So they've lived for 10 years following detection, diagnosis, and treatment of that cancer. Let's suppose the same individual was in a screening program for that specific cancer, and the cancer was detected on screening at the age of 45, so 5 years before they would have otherwise detected it by virtue of having symptoms. And let's say you didn't start treatment, or there's no specific treatment for the early diagnosis, and you simply started treatment at 50 and they still died at 60. Now, that particular patient who was screen detected would have lived for 15 years, whereas if they had symptomatic detection, they would have lived for only 10 years. So you can see that even without any specific or beneficial intervention for a screen detected cancer, just by treating them in the usual way, i.e. when they got symptoms, you spuriously are increasing their life expectancy or survival after diagnosis by an extra 5 years without really having offered them any treatment. So this is what is called lead time bias, and this is a fallacy seen in so many observational screening studies that observational screening studies are now considered completely worthless, because they do not take into account the fact that lead time bias could have influenced their results systematically. And that's why it's important that randomized controlled trials are done for screening. And even in randomized controlled trials, sometimes over-analysis of the results can be influenced by lead time bias. Okay, so I hope that makes sense. The next is the bias of overdiagnosis, or some people call it length time bias. And I'll explain this with this figure. So let's assume that on the x-axis of this graph you have time, and on the y-axis you have extent of disease. And let's assume that we're talking about a specific disease which progresses over time, and some people die of the disease. So the first group of patients here over time succumb to the disease. And then you've got another group of patients where maybe the disease is a bit more indolent, and you have some patients dying of the disease, but other patients dying of natural causes, i.e. of causes unrelated to the disease, or what we would say competing causes of death. And then you've got a third group of patients who don't really succumb to the disease, but then end up dying of maybe a chest infection or a myocardial infarction or a road traffic accident and what have you, right? So, let's say that you are in a situation, in a setting where you're only diagnosing the disease after it becomes clinically obvious, i.e. when they get symptoms. So in that cohort, you're likely to see that a lot of people are going to die from the disease, and only a few people will die of natural causes. Now let's say for this particular disease or cancer, you implement a screening intervention, and then you're picking up the disease much early in the natural history. So this is the cohort. And you will see that a lot more patients that you pick up from this screen-directed intervention, you're going to pick up really early, and you will find that they're going to be, a lot more people are going to be dying of natural causes, because you're detecting them early, and you may be subjecting them to treatment. But again, there are these competing interests or competing diseases that would influence their mortality. Now, if you detect patients even early by introducing another more effective, what you think is a very efficacious screening test, what you're doing is you're going to be picking up loads and loads of patients who are going to be dying of natural causes. So picking up disease or detecting disease, either by doing excessive scanning, like CT scans and MRI and so on, and PET scans that we tend to do all too often these days, or by implementing a screening test, will result in the diagnosis of disease that may never become manifest in the course of the individual's lifetime. So that's a problem. That's the overdiagnosis bias or length time bias, which is a huge problem in screening tests. Okay, so take-home points. So we've learned before in the previous lecture that predictive values are what are really important for screening tests, and likelihood ratios are important for diagnostic tests, right? In the first lecture, we also emphasized how understanding pretest probability is really important to be able to use diagnostic test results effectively. If you do not know pretest probability, then you're not going to be in a position to use the results of the diagnostic test to the benefit of your patients. We talked about ROC curves in this lecture, and I hope you remember that ROC curves are useful for either comparing tests or for deciding what thresholds or cutoffs to use in a test that gives you a quantitative result, not a yes or no answer. And then we talked about screening briefly, and I explained what lead time bias means and what overdiagnosis bias means.
Thank you everyone for tuning in and listening. Until next time, keep running your life with our surgical podcast.